this is going to be the last. This is going to be the last session for the scheduled virtual medical rounds program. We may have more in the future, depending on what the interest is. There is no quiz for today up yet. I will put a quiz up later on today. Again, it won't be that complicated. What I want for you guys is, if you can, by the end of this month, by May 31st, finish all the quizzes. That way we can get a count of those that have gone through the program, have participated, and you can get credit for what you did. And I'll send you guys a certificate or something to show that you finished the program. Okay. Can everybody see the shared screen?
Yeah, I can see it.
Yes.
Okay, cool. Thank you. All right, so let's go ahead and get started. There you go. So we have a 56-year-old male who's coming in with abdominal pain. So it's been ongoing for the last year. It's been worse over the last 2 weeks. It's in the upper abdomen predominantly. It feels more like a pressure. He feels like he's not able to eat well. He gets full pretty easily, has some nausea, but he's able to keep the food down. He's not vomiting it up. And then he has no difficulty swallowing food and no difficulty swallowing water. So any thoughts off the bat for this patient? And he's presenting to the ER. If we're thinking upper abdomen, what structures are typically in the upper abdomen that we would want to think about?
Gallbladder?
The gallbladder, yeah. So gallbladder, traditionally, it's going to be right upper quadrant, right? So the right upper side of the abdomen, around where the liver's at. There is a lot of times, though, that patients come in with epigastric pain, so right kind of in the middle of the stomach, the middle top of the stomach, and that ends up being gallbladder pain as well. So you never want to discount if it's only in the middle or in the epigastric region. So gallbladder is definitely something we'd want to consider, especially if he's not really able to eat well. With gallbladder pain, typically you get pain after eating, and that's because the gallbladder is contracting. If there was an infection of the gallbladder or there's a stone stuck in the gallbladder, as that gallbladder contracts to squeeze the bile into the intestinal tract, that will cause pain. So people that aren't able to eat well, have pain after eating, you want to think about gallbladder. What else would you want to think about in the upper abdomen area?
The heart.
The heart, yeah. The heart, especially if, let's say this patient's having an MI that's presenting atypically, you want to consider the heart as well. What else?
The diaphragm.
The diaphragm, okay. So if he has some type of diaphragm injury or irritation, that may cause some pain. If we're thinking about the diaphragm, what around the diaphragm also can cause pain?
The liver.
The liver, okay. There's one other structure there.
The
Right
lungs.
in the up. What was that?
The lungs.
The lungs, that's more, yeah, but that's more kind of going into the chest cavity. If we're thinking about the abdominal cavity, right where the abdomen starts, what's that main structure there?
Pancreas?
Above the pancreas.
Is it the stomach?
The stomach, yeah. So that's good. We went through basically all the organs. The pancreas definitely can be pretty painful if we're thinking something like a pancreatitis. Just like the gallbladder, pancreatitis pain can happen. It can worsen after eating. Usually you'll have pretty consistent pain, but after somebody tries to eat, they'll feel nauseous, they'll be vomiting. And it's because, again, the pancreas is very involved in digesting food. So, yeah, so we have all of these different potential organs that may be involved. Why did I say that there is no difficulty swallowing food or water? Why is that important?
Is it because you don't want to relate it to the esophagus, maybe?
So what about the esophagus would you worry about? So if we want to relate it to the esophagus, right? So we swallow food, we swallow water, it's going down the esophagus. If he feels difficulties swallowing food or water, what do you think potentially may be going on?
GERD,
What was that?
GERD. So he has reflux.
The GERD will cause some nausea. It'll cause some pain. But what if you feel like the food is getting stuck in the esophagus?
Is it that the esophagus might be swelling?
It might be that it's swollen, but what if there was thickening of the esophagus? What if there was a mass in the esophagus? Would that cause difficulty swallowing?
Yes.
Yeah, right. So whenever somebody's coming in with GI symptoms and we're concerned that there may be an esophageal issue, especially if they're having difficulty eating, we do want to make sure that they're able to swallow food and water, because if they tell us, I can't swallow food and water, I just vomit it all back up, I regurgitate it back up, it doesn't even look like it's mixed in with, stomach acid or whatever, we get worried about an obstruction in the esophagus. Especially in patients that have lost a significant amount of weight because they're not able to eat. And that's the other component to patients that have difficulty eating. One way to see if, is it a very serious problem would be to look at weight loss. Questions about this at all?
Can you explain why weight loss would affect the esophagus?
So there's a few different reasons why. So if you're not able to eat, right? So if you swallow food, or water, mostly food, right? Because that's where you get your calories from. That's where you get your energy from. If you swallow the food and it gets stuck in the esophagus and you can't actually get it through, or you only get a small amount through because you're regurgitating or throwing up the rest, then you're not really getting those calories. So without those calories, your body isn't able to maintain that amount of those energy levels that it needs to actually maintain your weight. And so your body will start using the energy stores it has already, so through fats, through sugars in the liver, to power your body, right? And so if you can't get those calories in, you will lose weight. Does that make sense?
Yes, thank you.
Okay. So just to summarize, because there's going to be a few different parts of this patient's presentation. So in this beginning part, he's been having ongoing pain for the last year. It's been worse over the last 2 weeks. It feels like a pressure. He isn't able to eat well, but he's not vomiting. And he has no difficulty actually swallowing the food. He feels like he's getting full pretty easily. Any other thoughts before we move on to the next part? Okay, so, all right, so he has lost 20 pounds over the last month. He's had progressive fatigue. He's unable to keep up with his daily routine. He works as a construction worker and now has to rest at least 10 minutes every hour. And whenever he gets up too quickly, he gets dizzy. Any first thoughts about this part of the presentation?
Could this also be that he might have like vitamin deficiencies, like iron?
So yeah, that's a good point. What happens if you have low iron stores? What does that cause?
Anemia.
Anemia. Okay, exactly. So if he has significant anemia and his iron levels are low, that may, that may contribute to his dizziness. But we never want to say, okay, he has, it is, his symptoms are because of a mineral deficiency or iron deficiency, vitamin deficiencies, without saying, okay, but what's causing that, right? So he can have iron deficiency, but why does he have an anemia? Why does he have that deficiency there? Does that make sense?
Could we say that he might have those things because he's unable to eat, so he's not getting enough nourishment?
Yeah. So that's definitely one possibility. He's not getting enough nourishment. We would want to see with the labs to see if he's actually anemic or not. But if he hasn't really eaten well over the last year, let's say, and it's getting worse over the last few months, then he may be at risk of a vitamin or mineral deficiency. But on the other hand as well, if he's also not eating very well, his overall glucose levels may be a bit lower. He may be losing weight because he can't get the calories in. But we would definitely want to keep that in the back of our mind if there is any deficiencies, and why is it that he may have that. Other thoughts? What about the dizziness when he gets up too quickly? Thoughts about that?
Low blood pressure.
What about the blood pressure?
It's low.
Okay, so how does that work?
I believe that there's not enough pressure getting to the brain or other important organs, and so the person gets lightheaded very easily.
Yeah, so this is called or one possibility for this is orthostatic hypotension. So what that is when you're sitting down or laying down, gravity is not acting on your is not able to act on your vessels as much, meaning it's not bringing all the blood down. But as soon as you stand up, gravity starts working on those vessels to bring all that blood down to your legs, basically. And so when you stand up too quickly and the blood goes down to your legs, you're not able to your veins don't have a pumping mechanism there. They don't have that pressure system like your arteries do that will help push that blood back to your heart. So you're more reliant on your muscles contracting to help push that blood flow up. And the veins in general will have valves, so that helps prevent a lot of that backflow. But it especially in older people, when they have dilation of those vessels, some of those valves may not work as well. And so the blood that is supposed to be returning to the heart stays down into the legs. You have less blood flow return to the heart, which means less blood flow out of the heart, which means less blood flow to the brain, right? And so if we're standing all the way up, the brain is going to have the least amount of pressure going towards it because of that negative effect of gravity, and that will cause a relatively low blood pressure within the brain, causing you to feel dizzy. And the reason why you're feeling dizzy is because your body wants to basically lay back down, so you have an equalization of your pressure into the brain. After a while, your body will compensate, and it tends to compensate pretty quickly. But I'm sure all of you have gotten up too quickly and have felt some sort of dizziness. It's the same reaction. Just for some people, it may take much longer for that to improve and for that dizziness to go away. Questions about that? All right. So he's had progressive fatigue. He's unable to keep up with his daily routine. He's losing weight, and he's getting pretty dizzy when he gets up too quickly. So when I think of this, when I start to piece all of this together, it seems like he may have a volume problem, right? So whenever dizziness becomes an issue and it's, you know, within the realm of orthostatics where he's getting up too quickly, I always worry about volume, right? And he's becoming progressively fatigued. So I worry about, you know, is there something that is making his volume deplete, right? He does have some nausea, but he doesn't have vomiting. So he hasn't really been vomiting. So that we would remove kind of just volume losses through vomiting as one part of the equation. He hasn't really been eating well, so we can think, okay, maybe he's not drinking very well either. So is it possible that he is just not drinking enough water that's making him become very dizzy? Any other thoughts? Any other possibilities? I think somebody mentioned anemia or iron deficiency. So that's another possibility, right? Especially if he's having progressive fatigue. If you don't have enough red blood cells within your body because you're anemic, or you don't have the capacity to transport oxygen as well, you would become more fatigued. And we commonly see people in the clinic, in the hospital, coming in for fatigue. And anemia is always one of the things you want to look for. The other is like thyroid, and then see if there's any other causes for their fatigue. But anemia is really big, and it's something you don't want to miss. So just to summarize, he's been having abdominal pain. He's not able to eat well. He's feeling a bit nauseous, but no difficulty swallowing. He's lost weight. He's felt fatigued, and he's getting dizzy. Okay. All right, let's move on. So on top of that, he's having back pain for the last 2 months. It's located on the left mid back. It feels like a deep ache, and nothing has really made it better. His urine has become a bit more dark, and he believes it's because of a UTI. He's been treated for UTIs, for 3 UTIs in the last 2 months, and he thinks he has a resistant bacteria, so he started drinking cranberry juice, and his stool has been dark as well. So this case is loosely based off of a case I saw in residency, and if I remember correctly, the patient had been seeing doctors virtually, and that had caused, and that's why he was being treated for the UTI 3 times, and he hadn't seen anybody in person as of yet. So, thoughts about this at all? And we can take it up in pieces, right? So let's start with the back pain for the 2 months. It's in the left mid back. What would you be thinking about in that area? Let's go with Crystal. What would you be thinking about in the left mid back area causing back pain?
The kidneys.
The kidneys. Okay. We had a few kidney cases, so yes, absolutely, you want to think about the kidneys. Any other structures in the back that you'd want to worry about?
The adrenal complex above the
Yeah,
kidney.
the adrenals are there too. So yeah, let's say he had a cancer within the adrenal glands, right? That can possibly cause some back pain if the mass is big enough. What about the dark urine?
Blood related?
Yeah, it could be blood related. Yeah, it could be blood related. It could be depending on what he means by dark urine. If it's just if it's like red blood, if it's like dark red, then okay, yeah, possibly blood. What if they said like cola colored or like dark, like brownish?
The kidneys aren't working well enough to filter out the urine before it passes.
Possibly. it would be this question was a bit harder. So we think about something called rhabdomyolysis, which is basically the breakdown products of muscle get filtered into the kidney, and if the concentrations are too high, it can damage the kidney. And so let me see if I can pull up a picture real quick so you guys can see what I'm talking about. Here. All right, I think you guys can see that. Okay, so so this, I mean, this is a very small picture, but basically, this is a good picture. So this is kind of the urine color that we would typically be talking about, this like darkish, like almost dark amber color. And what happens is the myoglobin, actually I forget if it's the myoglobin or what the actual process is, to be honest with you, but basically the breakdown products of the skeletal muscle get filtered into the kidney, and that can cause damage within the kidney and cause that dark urine. And this is, I'll probably take a look at that later. And if you guys are interested, I can always send you some more information about rhabdo. But it is something that we would want to treat, because it can cause pretty significant kidney damage. And the way to treat it is fluids. You just pump the patient full of fluids and make sure that they and make sure that the kidney function is improving, and we monitor the urine output as well. And so patients that have like dizziness or have this dark urine, maybe they have a new exercise regimen, we always worry about rhabdo, because if somebody it does have a new exercise regimen and they are pushing their muscles more than they would have in the past, they can definitely develop rhabdo. I don't know if I told you guys the story before, but I had a patient in the hospital that had been training. I think it was for either he wanted to either go back into wrestling, or he was training for a marathon. And so that day he had done he had started doing squats, and the gluteal muscles are some of the biggest muscles in the body, along with the quad muscles and the hamstrings. And so his leg exercises over the last day or two caused him to go into rhabdo. And he was young. He ended up doing fine after fluids, but it is relatively common. So sorry, that was a pretty big tangent. Let's go back to the case. So he's had dark urine. We said maybe blood, maybe breakdown products in the from the muscle. I would be less inclined to think rhabdo if he hasn't really been exercising as much, though he has low calories. He may be breaking down more muscle. He's probably not drinking a lot of water either. What about UTI? Do you guys think that this is a UTI? Fatima, do you think that this is a UTI?
I think it's possible.
Okay.
There's a deep ache, and then
it's possible, right? It's possible. The thing is, he's been treated 3 times, and I'm assuming, and you never want to assume, right? But I would assume that he's probably been treated with different antibiotics. So if he's been treated 3 times already for UTI, it's probably not as likely that it is a UTI. We would still want to get tests. We'd still want to rule it out, but maybe a little less likely. And we'll stay with you, Fatima. What do you think about the dark stool?
We should see if there's any bleeding in the stool.
Yeah, we got to make sure that there's no blood, right? So dark urine, dark stool, depending on what he means by dark stool. If it was just like a dark brown, we'd still want to check for any blood, but sometimes we get concerned if it's something like melena. And I think I've talked to you guys before about melena, and I actually think I've shown you pictures of melena, so I don't think we need to necessarily show you another picture again. But if you just Google melena, you'll be able to see it. It's this dark, sticky, tar-like stool. Has a very distinct smell. And so if you're worried about melena, you always want to do a rectal exam and make sure that, and to see if the patient actually has those darker stools. The blood in the stool, sorry. And so what you would do is you do the rectal exam, you get a sample of the stool, you put it on these little cards that will basically turn blue when you put a solution on it. And if it turns blue, that means there is blood within the stool. And then you got to work up the patient for a possible bleed. I think Christina said potential peptic ulcer, and absolutely, ulcerations within the stomach can definitely cause bleeding, and then that bleeding will show up as darker stools. So to recap all three of those parts, right? So we have ongoing pain in the abdomen. He has felt nauseous but has been able to eat. He's been losing weight. He's getting dizzy with progressive fatigue. He's having back pain as well, and his urine is dark and his stool is dark. Okay, so this is, and I am going through this case with you guys because this is how people sometimes present, right? Where it's usually not just one problem. It looks and feels like a bunch of different problems, and so you have to decide, okay, is everything related? Is everything associated with one specific disease state? Or are these separate problems going on? Because he can have an abdominal problem, like let's say he has a peptic ulcer, like Christina said, and then he also has a UTI or he had rhabdo, right? So both of those can happen at the same time. But what I would say is when things start occurring around the same time, most of the time they're related, and you will usually have better luck trying to piece together things happening temporarily together. So around the same time, they may have the same cause. And so looking at, okay, what causes back pain and abdominal pain and stool changes, right? And trying to figure out what that potential disease process is instead of individual issues. So for this case, because it's a little less clear since he's been having the abdominal pain over the last year, you would want to say, okay, is there something going on for each of these different problems separately versus all together? I don't know if I'm making much sense, but so that brings us to what our differentials are, right? And we've mentioned some of them, right? We've mentioned anemia, right? That would explain some of the fatigue. We mentioned a peptic ulcer, which if we think about, okay, peptic ulcer, GI bleeding, causing anemia and fatigue, that kind of goes together, right? Doesn't really account for the back pain as much unless you're having a type of like radiating or referring type pain to the back. But yeah, it's possible. We said, I think, what else did we say? We said potential kidney issue, right? Maybe a UTI, but a little less likely because he was treated with antibiotics. But something else in the kidney, maybe like a kidney stone, like we talked about, maybe a possibility. Can potentially cause darker urine if it's blood as well. The other thing that may kind of fit in with a bleed in the stomach is sometimes that can cause darker stool as well. I mean, darker urine as well. Does anybody know why? Okay, so a lot of times it's because of the bilirubin, right? So bilirubin is a breakdown product of blood that gets excreted, and so if you're having a GI bleed and you're absorbing more of that breakdown product of the blood from the GI tract into your system, you can potentially have an increase in those breakdown products, which pigment the urine a darker color. And again, if anybody's interested, we can go. I can send you more information on that and what that actual pathway is. So we have a bunch of different potential problems going on, and at this point, it's actually going to be very hard to figure out what's going on just on the HPI, and you're going to really try to look at the history and the physical exam to narrow that down. Questions about any of that? All right. So I know our differentials are not as clear as they were in some of the other cases, but that is pretty common. And so this is a bit more of a complicated case in that sense, okay? So here's his past medical history. So he has no allergies. He is taking lisinopril hydrochlorothiazide. He has a history of controlled hypertension. No other past surgical history. His grandmother passed away from an MI. I believe it was at a very late age. And he has a 30-pack year history of smoking. He used marijuana in college. He used cocaine at parties, but he hasn't used it in over 10 years. He drinks 2 to 3 beers a week. He's married. He lives with his wife and 3 children. So let's see. Shadi, anything important on the past medical history?
Maybe that he smokes.
Okay, so yeah, so smoking is a pretty important thing to look at, and why is that?
Because it could cause a lot of it causes a lot of issues. I'm not really sure how relevant it is to the GI tract, but
Yeah,
usually it causes like copes and stuff like that.
So it can cause a lot of different issues, and you're entirely right. It can cause narrowing of vessels. It is a significant risk factor for cancer, right? So people with a high pack year history of smoking have an increased risk of not just lung cancer, but a lot of different cancers, including I believe including the stomach and the kidney as well. So 2 different areas that we're already looking at. So we would be concerned about a potential cancer there, right? And so absolutely, I think that was the big one that we wanted to make sure we take note of is that smoking history. I think everything else, he hasn't really used cocaine in the last 10 years. It's a little less likely that it's relevant now. And then he has hypertension. Depending on what his blood pressure is, it may or may not be relevant. So yeah, good job. So his vitals. So let's go with Dami. His vitals show blood pressure 110/66, heart rate of 110, respiratory rate of 16, temp is 99, and he's 96% on room air. Anything there stand out to you? Let's go with Elizabeth. Anything in those vitals stand out to you?
Well, the blood pressure is a bit low on the lower end of the spectrum. I don't know if that's, I want to say it's, at least like from what I know, it is low, but I don't know how significant it is.
The blood pressure is actually it is okay. The normal is around 120/80. People range anywhere between 100 to 120 systolic, and they can range anywhere from like 60 to 80 diastolic, and that's okay. The depending on where depending on what his normal blood pressure is, it may or may not be normal for him. So he does have hypertension. They say it's controlled, but if his control is like 130 systolic, this may be significant. But it's hard to say, and so you'd want to rely more on how the patient actually looks. But what else in there is abnormal?
The heart rate.
Yeah, so the heart rate should be below 100. He's at 110. So a patient that is fatigued, getting dizzy, and his heart rate is elevated. Do you have any thoughts on what can potentially be causing that?
Sorry, can you sort of like rephrase that question again?
Yeah, so if somebody who has a elevated heart rate, right? Their heart is working harder to pump, who is also feeling very fatigued and getting dizzy. Any thoughts on what can potentially be causing that?
I would believe that there isn't enough consistent blood flow in the body itself.
Yeah. So exactly, I would think the same thing. I would think potential volume problem, right? So his heart is working harder to make sure that the rest of the body gets enough oxygen, right, and enough blood flow. And if he's already feeling fatigued and he's getting pretty dizzy, that may mean that his blood volume is lower than where it should be. And so that heart rate is very important to be able to assess that and assess the patient's stability. So absolutely, good job. Everything else look okay on the vitals for you?
Yeah, for the most part.
Okay. Yeah, same. The 96 on room air, it's fine. I wouldn't be too worried about it. I would want to potentially keep an eye on it though, but it looks okay. All right. So here's his physical exam, and let's go with Joey if you're still here. Yeah, Joey. He looks well groomed, pleasant, appears underweight, is not in any significant distress. His head and neck exam is normal, no adenopathy, so no swelling in the neck at all. He's tachycardic, but a regular rhythm. His cap refill is 3 seconds, and his dorsalis pedis and radial pulses are intact. His respiratory exam is normal. He has tenderness palpation of the epigastric region, no rebound or guarding. Bowel sounds are present in all 4 quadrants, no suprapubic tenderness. He does have some CVA tenderness on the left. He moves all of his limbs symmetrically, and he has no notable rashes or lesions. So thoughts about that exam, Joey?
Nothing too crazy. I mean, we knew he was tachycardic from the heart rate. I think the cap refill might be a little high.
Yeah.
The CVA tenderness and then the tenderness in the abdomen are both, I think, important because we know he was having pain there, and that's just proving that there is some kind of.
Yeah, there's something going on there. So yeah, the cap refill usually below 2 seconds is normal. If a patient is cold, right, that may affect the cap refill. If the patient has a low volume or has a history of atherosclerosis, so like the vessels are narrowed and has a harder time getting blood flow to the extremities, that can be contributing. And so for those that don't know what a cap refill is, basically you squeeze either the toe or finger, and you see how much time it takes for the blood flow to come back. So from it to go to white, back to red. And so it's important to help us assess how blood flow is. And so it's very, if you do it enough times, you can kind of see what's normal and what's not. Sometimes in the beginning, it feels a lot more subjective, but it's an important clue. So yeah, I think for this physical exam, it basically confirms what we already have been told, right? He has some belly pain. His pain is in the epigastric, in that top upper abdomen region, and he has something going on the left side around the area of the kidney. So CVA is costovertebral angle. It's basically that the area between the ribs and the spine, and that's around the area of the kidney as well. All right. So usually at this point, we're going to kind of want to reassess our differential. So is there any thoughts on what you would be most worried about? It doesn't have to necessarily even be the right diagnosis, but probably the most worrisome thing you would want to rule out. And it could be very just a general problem that you want to rule out, not necessarily the end diagnosis. And I know this is a lot of you trying to read my mind. Philip, what do you think?
I would say the no rebound is kind of worrying. Like that kind of suggests to me there's some type of like, I wouldn't say, I think maybe some structural weakness.
So are you talking about on the abdominal exam, the rebound?
Yeah.
So rebound, what that means is when you push on the belly and you let go, that means that, so when you push down and let go, if the pain is worse when you let go and letting go causes significant amounts of pain, that may mean that there is you have something called peritonitis, where there is inflammation in the fluid in the area around the organs of the abdomen, and a lot of times that is indicative of a rupture of the intestine or the stomach. Basically, you're having contents within the intestines that aren't supposed to be there, going out into that aren't supposed to be in the peritoneum, going into the peritoneum, causing a lot of inflammation. And so if somebody has rebound, regarding that is traditionally something we would be very worried about, and we'd have to get surgery involved to make sure that they don't have a perforated intestine or stomach. And so him having no rebound is actually a good thing in this case. So what I'm trying to get at is at the very beginning, we kind of saw that he's been having fatigue. He's getting dizzy. He has a elevated heart rate, and cap refill may be a little bit delayed. Anything just broad, kind of what we want to do, looking at the labs, that we would want to rule out, just like getting a quick blood test. What would we want to make sure he doesn't have?
An embolism?
Not an embolism, but in the same system, right? So embolism, blood clots, but something in the blood. What would we want to make sure he does not have? And we kind of talked about it already.
I was gonna say troponin then, but no.
That'll be important. Make sure that his heart, there's no strain to the heart that's significant. But what about just like blood levels, right? What in a CBC, what would you want to make sure he does not have?
Could we check his creatinine to make sure that he doesn't have kidney disease?
Yeah, we would want to make sure that his kidneys look okay, but even before that, right? Because this is going to dictate how we're going to treat this patient. Whether we're going to have. What was that?
High white blood cell count.
Yes, the white blood cell count is going to be important. Make sure that there's no infection, but even above that, right? Just the baseline. He's getting fatigued, tired, dizzy. Yeah, Elizabeth?
Oh, so I don't know if anyone.
Sorry.
Okay, no, it's okay. You can go ahead.
No, I didn't know you raised your hand. My bad.
Oh, it's okay. No worries. I was just gonna say maybe in general, just note that if he has just a good amount of blood in his body, because
Yeah.
I know that you've mentioned that volume is gonna be kind of important.
Yeah. So
yeah.
anemia, right? We want to check that CBC, check the hemoglobin, and make sure that the hemoglobin levels aren't very low. Because if the hemoglobin levels are low, I think somebody mentioned at the very beginning iron levels, and iron levels are important in evaluating an anemia. So if the patient has a significant anemia, he's going to feel tired. He's going to feel dizzy. And a lot of that is because you just don't have that infrastructure anymore. You don't have the blood supply to actually perfuse a lot of your organs. So especially in patients that are tachycardic, right? You want to make sure that they're not anemic. Questions about that? And if you don't understand how I got there, let me know and I'll go through it again because it's an important point for this case. Everybody understands anemia, why that's important? Okay, so just looking at the labs, right? So white blood cell count, 6,000, hemoglobin 7.2, platelet 150. His BMP shows a sodium 141, potassium 3.6, chloride 101, CO2 of 25, B1 of 40, creatinine 1.8. His liver function tests show AST, ALT 10 and 17, T-bili 1.1, lipase is 25. Urine dip shows specific gravity 1.03. He has positive blood and otherwise was normal. So in these labs, what is important? Minal, what is important? What stands out?
If you look at his hemoglobin, it's like half of like the regular amount.
Mm-hmm.
Isn't the regular usually like 13.2 or 14?
Yeah, so depending male, female, it can range anywhere between 12 and 14. Yeah, so he has half of that. So 7.2 is what he's at right now. So that would cause that significant amount of fatigue. Now, there are people that have a low hemoglobin because they have chronic bleeds and their body accommodates. But even then at 7, they tend to be pretty fatigued. So absolutely, 7.2 is very, very, very relevant and something we'd want to make sure we want to know. What else in here is abnormal? I don't know EK. I don't know your name. Sorry, but what in here is abnormal?
Oh, sorry, I couldn't change it. Sorry, let me just keep looking at the screen real quick. Because I was gonna say hemoglobin too.
No worries. Yeah. So the hemoglobin is abnormal. In the BMP, there's something abnormal there.
Oh, BUN. BUN. It's 40. It should be 10 to 20. That's really high.
Yeah. So that is elevated. What else? Right next to it.
Creatinine.
Yeah, so the BUN and the creatinine are elevated, which both of those are indications of what organ?
Kidneys.
Yeah, so we have a kidney issue, we have an anemia. What about the LFTs, the liver tests? Anything in there abnormal?
I don't remember just for the LFTs.
That's okay. So AST, ALT are normal. T-Billy is a little bit on, I think it's either on the border or it's a little bit on the higher side. And what about the lipase? Do you know if do you know what organ that we look at when we talk about lipase?
Isn't that for the pancreas? But I don't remember the range. So
Yeah,
let's look at the range.
No, you don't have to look it up. It's normal. But yes, you're right. It is the pancreas. And then we'll stick with you for the last one. What about the urine? Anything in there abnormal?
The urine is slightly concentrated. Because
Yes.
it's, yeah.
Yeah, the urine is slightly concentrated. What about the blood? Is that normal?
I don't understand what the positive blood was for.
Oh, that just means that there's blood in the urine.
Oh, I see. Okay, yeah, that's not normal.
Yeah. So so he has an anemia. He has a change in his baseline kidney function, and he has blood in the urine. So this is aside from the anemia, the change in baseline kidney function and the blood. If we just had that, right, just those two, and he was having, let's say, flank pain on the left side, what would you? Is there any diagnosis that you'd be worried about?
So immediately just from flank pain and knowing he has concentrated urine and blood in the urine and issues with kidneys from the B1 and creatinine, I would think check his kidneys, see what's going on. Maybe he has an infection there somewhere. Something. Or also maybe see if it's radiation pain, just to rule out anything else.
Yeah, so an infection, the other one that we kind of talked about in the past cases was a stone too, right? So if he had a stone, a lot of time that can cause blood in the urine, cause that flank pain, cause changes in baseline kidney function. It wouldn't usually explain that low of a hemoglobin because you usually are not losing that much blood. So and just for anybody, now we have that significant anemia, right? That's probably the most important part of this case in terms of what we need to do next. Do we have a source yet? Do we feel comfortable that the urine is the urine or the kidneys are the source of this patient's bleed?
I want to say yes, but I also have a question when you mentioned kidney stones. Would kidney stones cause blood in the urine?
It would. So if the kidney stones go into the ureter, so in the tract that takes the urine from the kidney to the bladder, it can cause trauma in those ureters, causing a little bit of a bleed there, and you'll see that blood in the urine. So it can cause blood.
Okay, thank you.
Any other thoughts? Do we all feel comfortable that the kidneys are the cause of this patient's anemia? The kidneys or the urinary tract in general, I should say.
Isn't the stool also dark? So wouldn't we also have to check for that?
Yeah. And so that was something that was left out in the physical exam, which I just realized right now. We didn't do a rectal exam on this patient because he was having darker stools, right? Where is it? Stool has been dark as well, right? So he's been having darker stools, and so that, along with the GI symptoms, not being able to eat very well, we wouldn't want to say that this is all the urine, and you can lose a good amount of blood in the urine if it's been going on for a very long period of time. But I wouldn't feel comfortable, like Shadi's saying, I wouldn't feel comfortable saying that this is all just the urine. I would want to make sure that the stool is not positive for blood as well. So we have a potential kidney issue. We have a significant anemia. We have a possible bleed in the GI tract. So what imaging would you guys want to get for this patient? And I showed you one right now. It's a chest x-ray, which we got before we even saw the patient, because a lot of times the ER will get a chest x-ray even before we see the patient, just to make sure there's nothing going on in there. Any other imaging you want to do? And you don't have to say a specific imaging modality. You can just say, I want to image this part of the body. Minal, what do you want to image?
I'm not sure.
So we're saying potential kidney, potential GI issue. Where would you want to image?
Could we do a CT of the abdomen?
Yeah, that's what I would do. I would do a CT of the abdomen. If we have if we are thinking just kidneys, fast, depending on the hospital, you can always consider an ultrasound first to CDC a big stone or something like that. But usually CTs are pretty quick, and there's a lot more going on that I would want to also CT it. Would we be able to use contrast in this patient?
I feel like no.
And why is that?
I want to say because of like his BUN and his creatinine, like maybe we would want to add more. Honestly, I'm not sure, but I feel like the answer is no.
No, you're on the right track, right? The BUN, the creatinine is elevated. He is significantly above his baseline creatinine, so he has some type of kidney injury already. Contrast can injure the kidney. CT contrast can injure the kidney more. And so we wouldn't want to push this patient into kidney failure, right? A lot of this may be him not having enough volume to actually perfuse the kidney, and that's why he has a kidney injury. But I wouldn't want to give contrast in this case at this point, because we don't know that. So yeah, good. So for in the interest of time, I'm going to kind of just go through some of this imaging here. The chest x-ray, it looks pretty good. The margins look pretty good here. So if we want to do it through the like ABCDE system, we would look at A for airways. The airways here look pretty good, and it comes out in this way. It's not deviated one side or the other. B is your bones. So you want to make sure that these little, I don't know if you guys can see my cursor, but these the spinous processes here are actually, hold on, let me see. I can't find my little tool thing. So the spinous processes are midline, so they're these little circle things in the middle. They're at the midline. That tells you that the patient isn't really rotated. The clavicles are around the same height, so here and here. So that means, again, the patient isn't rotated. Each of the ribs look pretty good coming out. You don't see any breaks, and then coming up this way on both sides, they look okay. C is the cardiac silhouette. So that is the outline of the heart, and everything looks pretty good here. Everything is sharp as it goes down to the diaphragm. It doesn't look like there's any fluid in those areas. D is the diaphragm itself. So again, same thing. They're more or less symmetric. On the right side, you're going to have your liver. So that's why it's going to be a bit higher than on the left side, but these angles between the ribs and the diaphragm are normal. And then E is everything else. So you're just looking at the lungs. All the lung markings look okay. You have these coming out, but these are vessels and the airways coming out from that mid portion of the lungs. That's where it's more concentrated with structures. So you'll see kind of all these markings in here, but they look okay. As you go out, you have more of these like spidery white lines coming out, and those are generally the vessels in the airways as well. And you'll see with these vessels, they get smaller as they go out. It doesn't look like the ones at the top are usually going to be smaller than the ones at the bottom, which we do see here. If somebody had congestion of the vessels, meaning they had something like heart failure and the heart wasn't able to actually pump the fluid out as well, and it starts to back up in the lungs, you'll see some of these vessels more prominent coming out to where the end of the rib cage is, and then you'll also see the top vessels just about as big as the bottom vessels as well. So basically all to say that this is a normal chest x-ray. Now here's just a slice of the CT. Does anybody see anything abnormal in here? Joey, I'm gonna pick on you. What is this structure right here?
Is that the liver?
That's the liver. Perfect. What about this over here?
I would assume it's a kidney.
No, it actually, is it the kidney? It's hard to say with reference. It doesn't. I would probably say more spleen, maybe.
Okay.
What about this up here?
Is it the stomach?
That looks like the stomach, and then this is also the stomach. So anything in here look abnormal?
Not really, no.
What about this? If you look at the thickness of the stomach here versus here, does that look the same?
It's thicker on the right side.
Yeah. So does this look normal, or I mean, do you think that this is normal or abnormal?
Abnormal, I would assume.
Yeah. So the lining of intestines should be pretty thin. It should be something like this, right? Where the actual lining itself is just a thin layer of tissue. It usually does not have this thickness. Sometimes the thickness can be because of inflammation. You'll see more prominence of the tissue because of that. But when it gets this big, right? When it's a pretty significant thickness, we get concerned about something else going on. What would you think? I mean, just a guess. What do you think that might potentially be?
I don't even know. Maybe like it's like a tumor. I don't know. It's huge.
Yeah, no, exactly. Cancer, right? So if tissue is supposed to be smaller, but then it's bigger, right? Possible cancer, right? So exactly. So this might be a potential cancer here. That might be that's a pretty abnormal looking lining and potential mass there. Okay. All right. So I think there's one more. I think I have another image. Yeah. Okay. What about this one? And we'll stick with you, Joey, if you don't mind. Just based off of symmetry, what is abnormal here? So let's orient ourselves actually. So the spine, right?
Yeah.
What's this right here?
Is that the kidney this time?
That's the kidney this time. What about this?
I don't know.
It's at the same level of the kidney, right?
Yeah.
So this is actually the kidney.
Oh.
But this is not supposed to be here, right? So again, principles of what we talked about for this one. What do you potentially think this is?
Another cancer, maybe.
Another cancer, exactly. So these are your two main vessels, the aorta and the inferior vena cava, and some more bowel here. So yeah, so you have these two potential masses, one right there, one right there. So oncology, so we would potentially say want to call oncology, right? But what is oncology missing? What would they want before you talk to them, before you get them on board?
Maybe a biopsy.
A biopsy, right? So my favorite quote from an oncologist in residency was "No tissue, no issue," right? So until they get the biopsy results, they have nothing to do, right? They need that tissue, they need that biopsy. So what do you think the easiest biopsy would be for this?
Would it be the kidney because it's closer to the like outside?
Yes and no. It is closer to the outside. It's actually a pretty common biopsy that they do. But we kind of talked about it, I think, for another case. What is another for the stomach? Let's say we want to biopsy the stomach. How would we get to the stomach?
We would need to open the chest cavity, the abdominal cavity.
Nope.
No.
No. Think about it. How do you get to the stomach?
Esophagus.
Esophagus. So what do we do? What do we do relatively routinely if we want to take a look at the stomach? I think we talked about it for the patient that had cirrhosis and had vomiting blood. Do you remember what we did for him?
I don't.
It's okay. Anybody else? Anybody remember? I showed you some images of the procedure. That was a while ago, so it's okay if you guys don't remember. Yeah, Elizabeth?
Would it be an endoscopy?
Yeah, so an EGD. So I think, Joey, you're on the right track. We in terms of we got to get that tissue, but the easiest way is you put a scope down, right? You take a look at the esophagus, at the stomach as you go down as well, and see if there is something to biopsy, right? If there's an abnormal mass, if there's an ulceration, if there's something that looks like a potential cancer, you'd want to biopsy it, and that's probably the easiest way to get tissue. Probably much easier than getting the sample from the kidney. So that's what they did in this case. So EGD, and sorry, trigger warning if you don't like medical images, showed this mass in the stomach, and these actually aren't the images from the case itself. I wasn't able to go back into the chart to find the images. So these are the images that I found that more closely resembled what we saw. So we had this abnormal mass in the stomach, and then we had in parts of the stomach as well, we had this like blackish ulceration, and one of these masses was actually bleeding. And so what the GI doctor had to do was try to cauterize it, try to stop the bleeding itself, so that the patient doesn't keep losing blood, right? So for this patient, and I think we have an imaging result here. So the CT, chest, abdomen, pelvis without contrast, was limited because of the contrast. Again, we couldn't do the contrast because of the kidneys. But there was a 3 centimeter mass in the antral portion of the stomach. So in the stomach, you had a 3 centimeter mass and a 5.5 centimeter irregular solid structure in the superior pole of the left kidney. And so for this image, that's actually the right kidney there. So just that on the other side, that's what they saw. The EGDs showed an ulcerative mass in the antrum of the stomach with notable oozing. A biopsy was taken and argon plasma coagulation used for hemostasis. So basically they tried to clot off the bleeding. And for some of these masses, it can be pretty hard to actually stop the bleeding itself, especially when it's because of a cancer. So patient was admitted for significant anemia and required 3 units of packed red blood cells. He was discharged after the EGD and the hemoglobin, once the hemoglobin was stable. So the biopsy returned as a clear cell renal cell carcinoma metastatic to the stomach. He was referred to Hem-Onc and started on antibody therapy, monoclonal antibody therapy. He required multiple hospitalizations for GI bleed to control the bleeding from the abdominal mass, and he required multiple transfusions as well. So this case was probably one of the most impactful cases that I had during my residency. One, because it was very complicated, and it was the first case. I was a intern, so it was my first year, my first month on medicine as well. And the doctor that I was working with, I'll never forget him. He basically told me, "You're gonna go see this patient, but you cannot look at the chart. You have to go in blind and take a history and do everything like we used to do before we had electronic medical records." So I had no idea what was going on with this patient, but it was a really good exercise in showing the importance of good history taking skills, because part of this history taking for me was trying to figure out all the different possibilities and all the different potential organ systems involved. And so if I had the chart, thinking back, I may have just focused on the fatigue and the bleed and not really go into the urine, right? So I would have not known that he'd been, because everything is so quick, I may have missed that he was treated for 3 UTIs in the past, that he had some dark urine, that he's been having some back pain, because I may have just focused on the potential bleed. And so, or maybe I didn't ask about his stool and I didn't even catch that that his stool was dark, right? He may not have told me that. So this is why good history taking is important. It makes for a more complicated picture, just looking back at all the information we gathered. And this is just some of the information I gathered. It is not all of it. But looking at it from just the history perspective, it may seem like, wow, there's a lot of issues going on with this patient, and there absolutely was, but it made sense in the end, right? Once we start piecing together all these different parts of his story, and then starting to look at the more objective information, his vitals, his physical exam, the labs, it became more clear what was going on. And then in the end, like, imaging is very, very helpful, especially if you have a specific area where, the patient's complaints may be originating from. So this patient ended up passing away from his cancer. And again, all of the details for this case is not, they were changed. It was changed, and there are aspects of this case that come from other cases as well. But this specific patient that I had seen was an incredibly humble and nice guy, and I actually visited him before he passed away at his home. Unfortunately, I wasn't able to go to his funeral, but it was, I think, that interaction of going to see him in his home and meeting with his family made everything more real for me, if that makes sense. And it makes it so that you kind of see the person behind the diagnosis as well, which is something that, as you guys go forward and you go into your practice and you start learning the medicine, you're going to be bogged down by a bunch of different medical facts. I want to make sure that you guys never forget that there are people behind what you're treating, right? And so hopefully this case kind of illustrated that, and you got something out of it. And I know it was more complicated than past cases, but this is what you're gonna be seeing. So, any questions about that at all? Okay, so that was our last case. We may continue. We may do something else, a different format or something if you guys are interested. There's a lot more cases that I've been seeing that are very interesting as well. So if you do want to continue some form of this, please let me know and provide that feedback, okay? One last thing that I wanted to share with you guys, as I know some of you are starting to apply to medical school, and some of you are getting accepted to medical school, and even those that are a bit of a way off. One thing that we really don't learn too much about is in medicine is finances in general. And let me stop sharing this. And so medical school is very expensive. It is very, very expensive. But the one thing that I would want to impress on all of you guys is, even though you have to take out loans, or most of us have to take out loans, there is a way to pay them back. But I want you guys to be very cautious. And I know this is a very sharp kind of change in topic, but I do want you guys to be cautious and think about what that means. And so just to give you a quick example, right? One of my favorite sites to look at, what is the cost of going to medical school, or costs of just things in general. If you're looking at buying a house, if you're looking at, credit cards, whatever. One site that I really like is Bankrate, and no financial disclosures. I don't have anything to do with Bankrate. It's just a pretty good site. And so they have this student loan calculator, which is really, really, really good. And it gives you information about what all the different loan types are for the student loans. So I want you guys to look at it. If this is new to you, I want you to take a look at it and see. But I pulled up the UCLA School of Medicine tuition and fees. And so if we look at the average tuition and fees for somebody that goes to UCLA, it's about $38,000. Let's say $38,000. If you're a resident of California. If you're not a resident, it goes to about $50,000. So to make things easy, right? Let's say $50,000. It's going to cost $50,000 to go to medical school at UCLA for 4 years. So that's $200,000 in loans that you're going to have to take out. So, and this is just tuition and fees, right? This is not cost of living or anything else. And so most people will want to try to pay off their loan within 10 years. There's loan forgiveness programs and other things that you can do to help with that. But let's say you're going to completely pay off the loan in total. And let's say the interest rate, I believe for unsubsidized loans, I believe it's 7%. It may be 6. I don't remember at this point. So if you calculate that $200,000 loans over 10 years, over a 7% interest rate, you're looking at about a $2,000, $2,300 a month payment, which for some people that's rent, right? So you're paying this plus rent. And so at the end of everything, that $200,000 loan is going to cost you about $78,000 more. And I show you all of this not to freak you out, but just for you to be aware of what it costs to go to school. And this is why it's so important, if you're going to go to medical school, that you're not doing this for money, right? Because $278,000 in debt plus your interest, right? This is interest over the time as you start paying for it. You usually aren't paying anything for the 4 years of medical school and your interest is accruing at that time, and you're not paying anything during your residency either, for the most part. Some people are able to afford it, and so they do, but that is between 7 to 10 years of not paying. So this 200,000 will actually probably be closer to about maybe, and these are just guesstimating, it's probably like 250 by the time you're out. And so your monthly payment's about $3,000, a little less than $3,000 a month, and you're paying about 98,000 more in interest. So again, not showing you all this so that you freak out, because your salary is higher than the average US American salary. It's more for you to understand that you're going to have this payment, this $2,900 a month payment on top of what your cost of living is. And so it is hard, but it's doable, and you will come out of it okay, right? People's monthly salaries can range anywhere between after tax, probably about above 10,000 a month. So you should be okay. But again, there's a lot of other, and I'm not telling you to just you guys, this is kind of anybody else who sees this. There's a lot of other ways to make money. Medicine, you have to do it because you love it, right? Because it's not a get rich quick type scheme, and it's definitely not quick. So make sure whatever you go into, you really love what you do, and you think about whether or not it's worth it. If anybody has any questions at all about how to pay for medical school, how to finance it, what are the different options available, please reach out. I don't want this to be scary. And again, I don't want to discourage you from going into medicine. I just want you to be aware, because to be honest, I didn't know any of this when I went into medicine. So questions at all about any of that, about anything at all? All right. I'll stay on until everybody. Yeah, Jihan.
I just had a quick question. Can you repeat what you mentioned in the beginning of the class when you were talking about the certification for and credit for this program? I didn't really catch that.
There is no cost for this program that we're doing right now. There is no cost. It's all free. So as long as you do the coursework that is on Scholarly, you turn in all of the quizzes, which the quiz for this one will go out a little bit later today. As long as you do all that, you'll get credit for it. You don't pay anything. So yeah.
All right, thank you so much.
No problem. Yeah, and I'll stay on until I answer all the questions. And if there's no questions, I hope you guys all have a good day. And thank you for making the last 10-ish plus weeks enjoyable. So yeah, reach out if you guys need any other help or have any other questions. Okay.
Thank you so much.
No problem. Take care.
You too.
Thank
Hi,
you very
Dr.
much.
Just one last question. I'm so sorry. The quiz about the last session, I was unable to find it because I didn't attend that session. Is there a quiz for the last session, or was it taken off?
Yeah. No. So they're all up still. I haven't taken any of them off. So you're able to go to the site, and I'll send you guys an email once this next quiz is out. I'll send you all an email. And there's 9 different quizzes that you have to fill out, I believe. So I'll send that to you.
Thank you so much, Doctor. Have a great day.
You too.
Thank you. Have a nice day.
Thank you. You too.
Thank you for such a great course.
I have a question about, I think the chest pain module, is that included in the quizzes?
Yeah, so I would want you to also do the chest pain module. I don't remember, I didn't put an abdominal pain module in there. So yeah, the chest pain module I would want you to do. And so I do know the quizzes there are hard. And so if you are struggling with it, maybe we can put together kind of just we may do that, just put like a review session on the quizzes and so that we you can know the answers to that and know the reasoning behind it. But I think I took off the minimum score. So if you just complete it, that should be sufficient, but I'll double check.
Thank you, Dr. Noxie.
No problem. Any other questions? Any other questions, guys? All right. Well, hope you guys have a good day then.